Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Oxnard Health System, and Humana to bring Oxnard's Hello Health weekly education and information series to television. Tonight we're going to be talking about the advantages of injection therapy for pain relief. Dr. Andrew Gottschalk will be our guest. In the second half hour of our program, we'll be taking your questions, as we always do, live by phone at 504-866-3200. That's 866-3200. And by email. You can email your questions to us right now at this address, hhquestions@wlae.com. Well, tonight on the program, we do welcome the Director of Primary Care Sports Medicine at Oxnard, Dr. Andrew Gottschalk. Dr. Gottschalk is an orthopedic and sports medicine specialist trained in advanced injection techniques. He specializes in the treatment of both sports injuries and degenerative joint diseases. He's the Director of Non-Operative Sports Medicine, which means he doesn't operate, at the Oxnard Sports Medicine Institute, and the head medical team physician for our New Orleans Pelicans. And we are pleased to welcome to the program and to New Orleans, Dr. Andrew Gottschalk. Good to have you with us.
Thanks for having me, Tom.
Yeah, short timer, not in that you'll be leaving, but that you just got here, right? About 3 months or so?
Yeah, not even half a year.
Okay.
Started last September.
Okay. How did you end up in New Orleans, and how did you end up at Oxnard?
Oh, I got engaged to a gal who is a Tulane University graduate, and she loves this town as much as I love her, and we decided to come here and make a go of things, and it's been wonderful so far.
Terrific. When was it that you thought you might have an interest in medicine, and was there anyone along the way that kind of put you on this path?
Yeah, I'm originally from a small town in the northern forests of Michigan. A small town nobody's ever heard of, and it was a one-doctor town. And back then, when I was a kid, I thought that one doctor was really, really cool. And along the way, I looked at doing other things, and nothing held my interest quite like doing medicine. So from kind of early on in my life, I started walking down that path and was mesmerized by it ever since.
If he's the only doctor in town, he's probably a general practitioner. So how did you end up in this area of specialty?
Yeah, well, so you're right, I set out to kind of be a general practitioner, to be a family medicine doctor, and in medical school I looked around and saw a lot of things that I liked, but I liked the all-encompassing aspect of family medicine and primary care, and decided to go with that. And so in the middle of my, after medical school, my family medicine training, my residency, I met a sports medicine doctor who had done family medicine training before his sports training. And I thought he was great and did interesting and fun things, and decided that I wanted to do what he did.
And was there some excitement about coming here and working with a professional team? And you've worked with athletes before. You played a little ball yourself back in the day, right?
Yeah, well, the town was small enough, and our high school was small enough that to field a team, every kid had to play. So I played every sport there was. I played football, I played basketball, I played baseball, I ran track. I did everything. I wasn't good at everything, but I was good at a couple of things. I gave it a go. And so that kind of gave me perspective that I use now. When I came out of fellowship training, my sports training ended, I got involved in Division I basketball. I was the team physician for the St. Bonaventure Bonnies, a small school up in rural western New York. And that was a good jumping off point for the job I have now, because we worked really hard covering that Division I basketball team, and there was an opportunity to come down here and work with the Pelicans, and that was a good place to kind of get on board.
People think, man, it must be great to work with a professional franchise. What's the upside, and what are and I know you haven't been doing it that long, but what's the downside in working with professional athletes, keeping all confidences to your patients?
Working with professional athletes is the chance and the job of a lifetime. It is always exciting. Every minute of every day is exciting and fun. I don't know that it's a downside, but I think it's interesting. The other day there was a Pelicans game, and I was woken up that morning at 4 in the morning from a phone call from one of the athletic trainers about an issue with an athlete. I took care of that. And all throughout the day that I was running my own clinic over in Elmwood, I was dealing with Pelicans issues, with a phone call here and an email there, and taking care of this or putting in a prescription for that. Worked the whole day in some way. That night there was a Pelicans game. Worked and covered this Pelicans game where I sat there on the sidelines with my colleague, Dr. Scott Montgomery. And at the end of that game,
he's the surgical side.
He's the surgical,
right.
the surgeon for the team. And at the end of that game, we worked a hard day and shook hands. And I was walking out that night, and somebody stopped me and said, "Hey, Doc, you didn't have to work today. That was great." And it took me a second to figure out what he meant. What he meant was nobody went down on the court. Nobody went down on the court. We didn't have to run out of the court. We didn't have to do that. But this massive amount of work that goes on behind the scenes, people don't see. And so I don't think that's a downside. I think that it's an interesting side.
I think just a couple of observations, and you can share with me. I would think when you have athletes who make as much money as these athletes do, you've got their own agents, and in some cases maybe even their own medical specialists with their own opinion. So you might have that to worry about. On the other hand, you've got all the money in the world. I mean, these guys are major investments, so no one's ever going to say, "Is this covered by insurance?" Right?
You know, my only point of perspective is the Pelicans team, and I think those athletes are so tremendously educated as to the health of their own body. They are so involved and so eager to be involved and so happy to be healthy and so happy to work with us as a team. And some of them do have other physicians who they will use for opinions.
And not just here. This is all over.
Right? Well, this is all over, absolutely. But they are so involved to a wonderful level that's really a pleasure to work with.
And lastly, your other observation was they're just good guys. You enjoy being around them.
They are just good folk, and that makes any job, whether you're working with professional athletes or whether you're working with the custodial staff. Good people are good people, and it's a pleasure to work with.
Yeah, and that's not always the case with all professional athletes, so it's good to hear. Well, we are talking about orthopedics tonight. So when we talk about orthopedics, exactly what does that encompass?
So orthopedics is a fun and exciting field. It deals with the bones in the human body, the skeleton of a human being, and all of the soft tissue that hold those bones together, the ligaments and the tendons and the cartilage, and all of the soft tissues that make those bones work together and support us as a person.
Okay. Is there a typical way to treat muscle and joint injuries? And there's probably a spectrum in that area.
There are three main groups of treatment for bone and joint injuries. The classic conservative way to treat bone and joint injury is rest and anti-inflammatory medicine and rehabilitation, physical therapy, reworking muscle groups, things like that. The other two groups are one, surgery, orthopedic surgery to put bones and joints and tendons and things back together. And then what I do a lot of, which is injection therapy, where you go in with a needle and you deliver some sort of medicine to a specific joint or a specific muscle group where you want it to go. So by and large, those three groups are the main ways that we treat orthopedic problems.
And then surgery, obviously, is oftentimes the last resort.
Yes. I would say any time somebody takes a knife to you, it's a big deal. Surgery has a very appropriate place in the treatment of orthopedic and musculoskeletal problems, but it's one that we take very seriously because surgery obviously has its risks.
And the back and spine fall under orthopedics?
Back and spine often do fall into orthopedics. There's a fantastic spine orthopedist at Oshner right now.
Okay. At what point would a patient consider injection therapy, assuming we've tried the rest, tried the physical rehabilitation?
That's right. There are a few different reasons. So I think you're right. I think thing number one is the basics aren't cutting it. You've tried the rest. You've given the muscles time to regroup. You've tried a course of oral anti-inflammatory medications. You're still having difficulty. Maybe you've tried some physical therapy to rehabilitate a muscle group. So they're just not getting the job done. Other times, which is important in the sports medicine aspect of my field, is rapid recovery is important. Maybe you don't have time to rest before the next game. Maybe you don't have time to have a surgery that might need to be done at the end of the season, in the middle of the season. So in the middle of trying to get things through, you're going to turn to something that's more rapid onset, easier to do, doesn't have as long of a recovery time. Safety, I tout with injection therapy because the risks of injection therapy are minimal. For example, supposedly 1 in 40,000 injections gets infected. It's rare enough that I have yet to see it in my career, knock on whatever this chair is made out of. So I really tout
only the best.
Only the best.
That's right.
And then finally, back to surgery, it's either not indicated or unwanted. So some people say, hey, I need surgery in the future. I don't need it now. Let's try an injection in the meantime. Or surgery isn't indicated. There isn't a surgery that would help with that problem at all, but there is an injection that might. Okay. So for all those reasons.
I'm going to pay honor tonight to a sports writer, a longtime sports writer in this city, Marty Muley. who wrote for the Times-Picayune and was an incredible human being, but even an incredible sports writer. And in taking his class at Tulane, of all things, his lesson was, and I'll get to where this story's heading and how it relates to you in just a moment, but the one thing he said in sports coverage is you would never criticize a high school athlete. A college athlete, depending on if the story impacted his play on the field. And professional athletes were no holds barred, however you're going to cover them. They're professionals, they're being paid for it. So I ask you this question. You talked about getting back on the field. Well, athletes need to get back on the field at all levels. You're working with professionals with the Pelicans. These are adults. They can make their own decisions, perhaps along with some others, agents and the rest. In college, again, for most players are going to be adults over 18 years old, but high school athletes. So how do you feel about injections to get someone back on the field quicker? And what are the risks with injections that take the pain away and allow someone to play, but perhaps may lead to other injuries? So help us out in that area.
Yeah, it's a fair question and one that I am asked not infrequently. I would say this: health and safety is my job. I mean, it's my job to keep athletes playing, but it's my job to keep athletes playing safely. If there is a major health risk, they don't play, regardless of if they want to or not, regardless of if a high school patient's parent wants him or her to or not, regardless if I want my team to have a player to play or not. Their health and safety is why I am a doctor, why I am not just in sports medicine, but I'm a sports medicine physician. For example, if a patient of any age, an athlete of any age, has a concussion, they can't play. I care too much about his or her brain. I care too much about his or her brain now. I care too much about his or her brain in the future. So regardless of what level of play we're talking, he or she can't play. Sometimes an ankle sprain, depending on how bad it is, I will allow to play. And I don't think that depends on whether it's a high school or a college or a professional athlete. I think it depends on, one, how bad the sprain is, and two, if there are any associated risks. What I mean by that is with orthopedics and musculoskeletal medicine, when you damage a joint, it is inherently less stable. So the risk is you damage it further. You damage it further. Some patients, athletes, some parents are okay with that risk in certain situations. Maybe it's a playoff game. Maybe it's a game against an intense rival. So I think there are times where I say an athlete's out. If it's a concussion, an athlete's out. If it's a spinal problem, if it's a neck problem, if it's something inherently dangerous, regardless of the level of play, that athlete's out. And otherwise, for some other problems, I might let a patient play. I might let an athlete play as long as they understand that there might be associated risks.
And with a high school student, obviously you'd go beyond coaches. You would bring parents into that discussion.
That's right.
It would have to, right?
And I think a wonderful thing about America 2016 is just how involved parents are in the sports participation of their children. I think it's kind of in vogue right now to one, be a high school athlete who's playing in sports, but two, be the parent supporting that high school athlete. And so I find in New Orleans and all over the country that families are very proactive. They're very into it. They're very supportive of one another. And I will have a high school patient show up at my clinic with his mom, with his dad, sometimes with his grandma, who are all interested in being involved. And I think that's a wonderful thing.
And who should make the final call? The athlete, the parents, the coach?
At the end of the day, a doctor works for the patient. So the athlete gets to make that call, unless he's underage, in which case it's a parent or guardian's ultimate call.
All right. Do these injections hurt? So you're in the business of giving injections.
Yes.
Well, no one likes to get shots.
No one likes to get shots.
And this is what you do for a living. Does it hurt any worse than the kind of shot I'd get when I just go to the doctor's office?
Almost always no. Really, how much a shot hurts is dependent on the size of the needle. In general, we use tiny, tiny needles. And by the time I'm recommending an injection, by the time I'm recommending poking a needle into you, the pain that you're having is worse than anything I could do to you with a needle.
Give me the quick 1 or 2 seconds for the long haul.
Yes, that's right. I mean, it's a small price to pay for pain relief.
Okay. How do you determine where the injection is? I mean, so I've got pain in my knee. How do you determine exactly where you're going with the injection? This is in general, because we're going to talk about all sorts of injections here in a moment.
Absolutely.
Where are you going in, and does the injection treat the entire area and take the pain away from the entire area, or is it laser targeted where you're looking for just the specific area of pain?
Almost all joints in the human body are surrounded by a tissue-thin capsule, the synovium, the joint capsule. And it's a tissue-thin balloon, and it surrounds a joint like the knee. And so that's why you'll see doctors, some of them go in here, some of them go in here, and they poke into that balloon from all different places. But by and by, as long as you get the medicine into that balloon surrounding the joint, the whole joint sees it. So oftentimes the answer is, once you're in, you're in. For some of the more complicated things, we do target certain places, but that's rare.
Okay, and you said you might go in here and there. Is that the same? Are you going in multiple times usually?
Different. Oh, fair to say. No, I think some doctors prefer to inject the front inside of the knee. Some prefer to inject the front outside of the knee. There was a paper that came out a couple of years ago that said that the safest, most accurate way is to go kind of in the upper outer corner of the knee. So most of us, I think, have started doing that. But there are different ways to skin a cat. There are different ways to inject a knee, and by and by, all the medicine goes to the same place.
Okay. This would probably be an extreme case, but are there times you have given an injection during a game? And so how quickly does it take? And is there additional risk with the injury just happening and now getting right back on the court onto the field?
I think it's rare, but there are times that we'll inject right in the middle of a game. I don't know that there's any greater risk to that than there would be. And again, the ankle analogy, where if you're playing on a joint that is hurt, that is inflamed, that is irritated, it's inherently less stable. I don't think that the injection itself would make that any more or less.
Okay, so let's talk about the different types of injection therapies, and let's start with the standard injection therapies, which would include what?
So really, fundamentally, joint injections started with steroid injections, and that's this guy you see on the left-hand side of your screen.
That's a lot of steroids.
That's a lot of steroids. So there are steroid.
Or a lot of hard work.
A lot of hard work. So fundamentally, there are steroid injections and there are gel injections. Those are the two fundamental types of injections, and we'll get into both of those in a little bit more detail. But I think people hear the word steroid and they associate it with PEDs, performance-enhancing drugs, where athletes will take illegal substances to beef up their bodies. It's not the type of steroid. Well, it's not exactly the type of steroid we're talking about. So steroid injections should start with a simple explanation first, which is all of our bodies make steroid. We make natural steroid, and that is circulating in our body at all times. Now, when you have a joint that's hurt, it is almost always in pain because of inflammation. Inflammation does 30 different things in the human body, but two that people tend to care about are pain and swelling. So in your body, there's a balance between inflammation pushing one way and steroid, natural steroid, pushing the other way, and there's an equilibrium there. When you're in pain and hurting and swelling, inflammation's kind of winning that battle. We can inject a couple of drops of steroid to re-equilibrate what's going on, hopefully reduce some of the swelling, hopefully reduce some of the pain. And that's why we started injecting steroids in the first place. And the steroids that we inject are a derivative of your own body's natural steroids.
Is it a different steroid that a player would use for performance enhancement?
It is. So now you have companies all around the world, some of them trying to make money by selling chemically changed variants of a normal human steroid to people for that purpose.
Okay. And so let's talk about gel injections.
Yes. So every human knee, for example, has fluid in it. That fluid is basically a motor oil. It lubricates the top bone, the femur, sliding against the bottom bone, the tibia. So your knee has motor oil in it, my knee does too. As we age, we make that fluid less well. Well, there were a couple of companies a couple of years ago that decided to make essentially a synthetic motor oil and inject that into, say, a knee joint to help with lubricative properties and things like that. So they're called visco supplements, but that is too long of a word for anybody to remember. So we call them gel injections, which is what they kind of look like. They're a little gooey, but that's the other fundamental one that we use.
What's the gel made out of? And
It depends on the company. Oftentimes a patient will come in and say, hey, inject that rooster's comb into my knee. And because the original one was made under the brand name Synvisc, where they actually took a protein derived from rooster's combs, ground it up, and that was this jelly, somewhat gooey substance. And now there are other companies that pretty much do the same thing with a non-rooster comb derived gel, but it's all doing the same thing at the end of the day.
You said the old motor oil, the one we're born with, that goes bad.
Yes.
Goes bad meaning dissipates, or is all still there, just it not doing the job? It's because you hear bone on bone.
That's right. So it's a complex question, and I'll try to simplify it as best I can. You still make it when you get older. You just don't make it as well. You make a fluid that isn't quite as viscous, that isn't quite as much of a lubricant, that doesn't decrease friction as much as we would like. And degenerative processes like osteoarthritis and other types of arthritis wear through cartilage cells. And the cartilage cells at the end of the day are the ones that try to make that fluid, try to make that natural motor oil as well as they can. So as those get worn down, they do it one less and two less well.
Before we get to the advanced injection therapies, let's stay here standard for a moment.
Certainly.
How do you know which one to use on what patient?
It depends on the situation, oftentimes. And it depends on age. So I think we used to always grab the steroid injection first. It was quick, it was efficient. When it worked great. It was cheap, we loved it. The side effects were minimal. Having said that, there are some minor side effects to injecting a steroid, which is a chemical that, like I said, your body already has some of anyway. And the gel injections, if anything, are even more safe than the steroid injections, which is hard to do because the steroid injections are so safe.
And the side effects, as minimal as they are, were what with steroid? Or are still what?
Or are still. You can get, there's some thought that taking way too many injections could be bad to the chondrocytes, to the cartilage cells that stick around in there. The jury is still out on that. But the thought is that if that were true, you wouldn't want to inject it too many times, for example. So you don't have that problem at all with the gel injections, which is, it's pretty benign stuff. I mean, it is as benign as motor oil. So I mean, if there are side effects, we have not figured them out yet.
And how long have we been doing gel? Have we been doing it long enough to know?
Many years. So not as long as steroid injections, but I think so. I mean, again, one of the reasons I love the injection field is just how safe they are. I mean, they're when they're helpful, they're so helpful. In my mind, the biggest side effect is that it doesn't work. I mean, it's not that you get sick or that you have some bad outcome. In my mind, the biggest risk of these injections that we're talking about is that you do it and it doesn't work, which is such a minor side effect. Oftentimes, the answer is, hey, you might as well give it a shot, so to speak.
And how do you know, how long is it before you know it works? So you give the injection in the office. Am I going to feel better right away? Or am I going to call you 3 days from now and tell you how I feel?
So when we use steroid-based medicines, if you read a textbook, it would say 5 to 10 days to feel the maximum effect. Sometimes people feel good walking out of the office, but we say 5 to 10 days to reach the maximum effect. So I say, hey, if you've had a steroid injection to a joint and you're not feeling better in a week and a half, it probably didn't work. The gel injections take longer, so the companies that make those say you give it up to 8 weeks to feel the full effect. So if you're not feeling significantly better in 2 months, it didn't work.
The sac you described that surrounds
yes, the joint
the
capsule.
joint, right?
Right.
So you put in the steroid. Mm-hmm. Now, is that like motor oil too, or no? Because you can't. There's only so much room in the sac, right?
Yeah, that's true. So if you have degenerative joint disease, you have arthritis. Itis in medicine means inflammation. So arthro means joint. Arthritis means inflammation of the joint. So you have too much inflammation in a joint, and it hurts you, because one of the things that inflammation does is cause pain. And so when we inject steroid into the joint, we are trying to get on top of that inflammation. We're trying to knock it down. We're trying to alleviate pain.
Okay. So, but you could try the steroid. That doesn't work.
Yes.
Then you go to the gel.
Absolutely.
Okay. But then there are more advanced
there
therapies.
are more, and this, Tom, is where things really get fun. So there are advanced injection techniques now that we're doing, and 2 of them that we're going to talk about are platelet injections and stem cell injections. But they're under the umbrella of a class called orthobiologics. So ortho, because we're talking about orthopedics and bones and joints and muscles and everything else. And biologics, because they are biologic. These are, in a way, they're medicine, but they are coming from you. So when you inject a non-you thing into you, you have the risk of having some foreign substance in your body, whether that's a medicine or anything else. Orthobiologics are where we take your blood or your cells from point A, inject them into point B, and they help with pain or damage in part B, and it's a wonderful thing.
So let's start with platelets. Where do you
Certainly.
harvest the platelets from, and how does it work?
So many people have heard of PRP. PRP stands for platelet-derived plasma. So what we do is I have a nurse come in and have her act like a vampire and take some blood out of one of your arm veins. And then we put it into a centrifuge, which is a machine that spins it really, really fast. And what happens then is the red blood cells separate from other chemicals in the plasma of the blood. And then we take that plasma in the blood, the plasma of the blood that has a bunch of healthy chemicals that promote healing. And we inject that at a site that's specific. So if you have a degenerative knee, we can inject it into the knee and try to promote some cartilage healing, for example. If you're an athlete and you have just strained your hamstring muscle and you're trying to get back to play as soon as you can because it's not the end of the season, it's the middle of the season and there's some time to go, we can take some of your blood, spin it down, take out some of those healing growth factors and inject it right at the site of the muscle damage and promote some muscle healing.
If these are advanced, does it mean they haven't been around as long? And how long have we been doing platelet injections? And what about the success rate? What have you seen?
Not that well. I'll tell you, it's almost hard to say. They're so new that there haven't been a lot of studies done on them, and that's tough when it comes to selling it to an insurance company, for example. So my experience with these orthobiologics, with platelet-derived injections, with stem cell-derived injections, is that they're very potent and very powerful, and people tend to do well on them. They're new enough that a study that says what I just said is not readily available.
Insurance companies not buying in yet?
And I think that's the issue. The issue is that these are wonderful, exciting, fun things fun therapies that have great potential for healing one, degenerative joints, and two, sports injuries, acute sports injuries. But you're right, they're not covered by insurance companies, so there is an out-of-pocket cost associated with them. So that's not true for the gel injections. That's not true for the steroid injections. That is true for stem cell injections. That is true for platelet-derived injections.
Okay, when people hear stem cells, immediately controversy starts to swirl. So.
They do, and I think it's similar to when I tell a patient, when I tell an athlete that I'm considering doing a steroid injection. Immediately their mind thinks of bad things in the media that steroids are associated with. And I think the same thing is true for stem cell injections. There is fetal tissue that gives stem cells, which is not at all what I'm talking about. So when I give a stem cell injection, actually I'm taking stem cells from your bone marrow, bringing it out, and doing a similar process to what I did for the blood, for the platelets, where I take some of your bone marrow out. Bone marrow is rich with stem cells. I put it in a centrifuge, I spin it down, I pull off only the layer that has those stem cells in it that I want, and they are yours. They are adult you stem cells.
Again, no foreign body and the risk that's associated with that.
That's right, exactly. So it is your cells that we are taking from point A and putting into point B.
When would you consider using one of these advanced therapies when the other two don't work? So you're always going to start with steroids and gel, or are there some people who would go right here first?
That's a good question. And the reason is when I give a steroid injection, I'm trying to go for pain relief. If I give your sore knee a steroid injection and it gets better, I have not healed the process. I've taken the pain away, I haven't healed the process. And the same, by and large, can be true for the gel injections, which is it is not stimulating growth of new cartilage. Helping with the pain, perhaps. Helping regenerate damaged tissue, no. So the nice thing about the platelet therapies, the nice thing about the stem cell therapies, is that there is some thought that those could promote healing of chondrocytes. Chondrocytes are the cells that give you cartilage in the knee. So we are actually trying, one, for pain relief, yes, but two, hopefully, in some way, some regenerative properties, which is not true for the steroid or the gel.
The gel is the oil. You're pumping the oil back in there that's not any good anymore. So I'm at the 5-minute oil change, probably longer than that in
Right.
your office in the 5 minutes. But how long does the gel last? When it works and when it lasts, how long does it last?
It's a good question that is hotly debated. The insurance companies will cover getting it twice a year. So they believe the answer to that is it should last at least 6 months a pop. And it depends on the person. A lot. When somebody asks me if an injection is going to work, I say it depends on two things. It depends on, one, how bad the damage is, and two, your genetics. Some people respond gloriously to steroid injections. Some people don't. Some people respond gloriously to gel injections. Some people don't. So some of it is a very nebulous. Your genes and the way you are put together. It is very much the will of God.
What about the advanced, we talked about the success rates of steroids and gels, which you've seen. What are you seeing? How many people are choosing platelets and stem cells? And what are you finding with results?
The truth is more every day. Our results have been stellar, have been outstanding, have been excellent. I think more people get into it every day. I think it is still new. It is still kind of riding the crest of the wave. I think a lot of people out there who would benefit from it haven't heard of it yet. And that is just a matter of time and getting the word out.
Hopefully we've helped do that tonight. And would age be a factor in any of these things? So the athlete, the 16-year-old who has a full career ahead of him versus the 70-year-old who wants to continue walking every day but is having a hard time doing that. Would that point you in the direction of one of these therapies?
There's a rule of thumb out there now, which is that for degenerative joints, you go for stem cells, and for soft tissue damage, a strain, a sprain, a muscle ache, a ligament being stretched out, you go for PRP. But they've both certainly been used across the board.
All right. Our phone number, by the way, is 504-866-3200, 866-3200. We're going to be taking your questions next. Or you can send us questions by email, too. The address is hhquestions@wlae.com. So what can we as patients do on the front end of any of these things, or certainly on the back end once we've received injection therapy, to increase? You said some of it has to just do with who we are and our makeup, but are there things we can be doing to enhance the chances of these injection therapies being successful?
There are, in medicine, there are so rarely absolute truths. I mean, I'm famous for saying it's rare that things are black and white or 100% true. There are two exceptions that I know of. When it comes to orthopedics, when it comes to bones and joints and keeping them healthy, the two things are, one, healthy diet, healthy weight. Excess weight is bad for any joint. And so no matter who you are, no matter how active you are, I say between now and the day you die, healthy diet. Keep the weight off. That's thing one. That is always true. Thing two is keep focused muscle groups that support joints strong. Keep them healthy. So for example, with a sore knee, I tell all of my patients to strengthen up their quads, strengthen up their lower extremity, their leg muscles. And the reason for that is I want the meat to be doing the work. I want the meat to be taking the shock. I don't want the bones to be taking the shock as they bonk into one another. With the shoulder and the rotator cuff, many people have rotator cuff problems that could be solved by keeping those muscles strong. And so I think two universal truths are, one, between now and the day you die, healthy diet, healthy weight, and two, stay fit.
And any general tips about the types of exercises, running versus walking, biking versus running or walking, swimming versus biking, riding, or walking? Any general tips?
Tom, that is a whole other hour of discussion that you and I can have next week.
And what do you do to keep? Obviously, you're in shape and fit.
Oh, I sure try. I try to play tennis and basketball on the side, and don't have as much time as I would like for either of those. I think a fundamental answer to the question you just asked was impact activities take their toll on lower extremity joints. Running takes its toll on knees and hips. It just does. Some people genetically can withstand those forces for longer than others, and some cannot. But in general, if it hurts you, I say back up a step. If you're a runner and it hurts you, try jogging. If you're a jogger and it hurts you, try walking. If you're a walker and it hurts you, try an elliptical. Try a stationary bike. Try swimming. Swimming is a wonderful exercise because it is zero impact on the lower extremity. I love swimming, and I love encouraging my hip and knee patients to try swimming because it's a wonderful activity. It's good for cardiovascular. It's good for leg muscles, and there's zero impact.
All terrific advice. We're going to take a break. We're going to come back with your questions. 504-866-3200. That's 504-866-3200. Or send us questions by email at hhquestions@wlae.com. Back with your questions in just a moment.
I need help finding a doctor.
Pace.
I needed help with my medication.
Pace.
I needed help getting around.
The Shirley Landry Benson Pace Center is a place that helps seniors remain in their homes providing the care they need. If you or a family member are over 55 years old, you may be eligible for benefits offered by PACE. For more information, contact us at 504-835-0006. PACE, caring for those who cared for us.
They say that when you're facing extreme danger, your life flashes before you. If you think that's sad, consider facing it before you even have enough life to flash before your eyes. Deaths and injuries can be prevented by using the right car seat. Visit safercar.gov/the-right-seat to know what is appropriate for each age and size.
Watching WLAE, New Orleans Public Television. Find us on Facebook and follow us on Twitter.
And welcome back to Hello Health on WLAE. Tonight we're talking about standard and advanced injection therapies for pain with Dr. Andrew Gottschalk. And let's go to your questions now. On line one, Floyd is with us, calling from Homa. Floyd, welcome to Hello Health. Floyd, are you there? If Floyd is there, we're not able to hear him here in the studio. Is Floyd there with us? Floyd, go right ahead. We're unable to hear you, but go ahead and ask your question if you would, and then maybe they can whisper that question back to me. But go right ahead with your question, Floyd. Okay, I tell you what, we're going to try to get Floyd back on the line, but in the meantime, we're going to go to an email. Doctor, here we go. How is it what you do different from what pain management doctors do? So what's the difference between what you do and what pain management doctors do?
That's a good question because there's some very good pain management doctors out there. I tend to deal with more, the sports aspect is much more acute, much more here and now, much more I was injured the other day and I need to get back to playing, or I need to get back to exercising, or I need to get back. So acute pain is one of my major specialties, and also degenerative joint pain is one of my major specialties. Pain physicians tend to see a lot of chronic, ongoing, lingering pain that can't be treated any other way.
Okay, good answer. Line two, Greg is calling us from Mandeville. Greg, are you there with us?
Yes, I am.
Great, Greg. Good to have you with us. Go right ahead with your question for Dr. Gottschalk.
Yes, doctor. I've been treated for about the last 2 or 3 years for really severe lower back pain. I've been told that I have 2 degenerative discs. I have arthritis. I have scoliosis, and I have twisted vertebrae for some reason or another, and I'm just wondering, would your stem cell and platelet therapy help me?
Thank you, Greg.
Greg, the answer is they sure could. The back is an incredibly complex system, as you have spent your lifetime discovering. And there's some very good new data out there to show that it certainly can be successful in injections in and around the spine. Absolutely.
Greg, thank you so much for your question tonight. Line 3, Merlin is next. Merlin, welcome to Hello Health.
Thank you. Dr. Gottschalk, I've got a problem with my right knee. You all can hear me, right?
Can hear you just fine, Merlin.
Okay. About 6 or 8 months ago, I went to an orthopedic specialist who gave me a steroid shot in the knee and told me in about a week or two I'd be feeling really better and calm. Well, the fact is, and I hate to say it, it just got worse, not better, but actually worse. And it's been getting progressively worse since that time. With just pain will come on and last for about 10 seconds, and then it'll go away. He told me at the time I was not a candidate for Synvisc. I'm just want to ask you, is it possible I may be a candidate for Synvisc? I have bone on bone. Is it possible I may be a candidate for Synvisc?
Synvisc, is he talking about gel there?
So
gel.
One of the gel injections, and arguably the most famous one, certainly the best advertised one, is one called Synvisc, and they were the first ones to put a product out, and they were the ones who used the rooster's comb molecules to make the gel. So they are called Synvisc. Excellent question. One, I'm sorry to hear about your troubles, and it sounds like you've had a miserable time, and that's a pain. Two, and again, the gel injections are so safe, I would say try them. Why not try them? I can't think of a good reason not to. And I would say, too, that oftentimes we will try steroid injections, and if they fail, that's a great reason to try the gel. I mean, if A doesn't work, go to B. And again, A is pretty darn safe. It fails, go to B. B is pretty darn safe. Why not give it a try? It's certainly easier than surgery.
If you're still there, I think you mentioned that your treating physician said you were not a candidate for Synvisc.
That's only confusing to me because I can't think of who wouldn't be. And if you're still there, I assume we're talking about degenerative change. We're talking about arthritis in the knee.
I think he's gone, but yeah.
Fair enough. It is so safe and so worth trying that I can't sit here and come up with a reason to not try it.
All right. Thank you for your call. Let's go to line 4. Charlie is next, calling us from Harahan this evening. Charlie, welcome to Hello Health. You're on with Dr. Gottschalk.
Hi, Dr. Gottschalk. How are you?
Hi, I'm well. Thank you.
That's wonderful. Listen, I actually have been in physical therapy since I actually started it like July of 14, and I pretty much kind of got released from it February of 16. I did my MRIs and everything. They've done like the 3 lower things of my spine. That's kind of degenerative. I have hip trouble. I keep falling on my knee. I have that going against me. And actually, I think my mother had arthritis, so I'm 59, so I'm thinking I'm like on the onset of that. And my therapist and my doctor wanted to give me some kind of injections, which we never did yet. So I'm still in limbo. I don't know. I'm still in pain. Somebody had gave me, when I went to the emergency room, they had given me something called, it's DICLOSENAC.
Diclofenac.
Yes.
Yes.
And when I call my pharmacist, they say, well, it's for inflammation, and I don't know what that means.
You can take diclofenac 2 different ways: orally as a pill, or topically as an ointment, as something you can apply directly onto the skin. It's a cousin of ibuprofen. It's an anti-inflammatory. It's a non-steroidal anti-inflammatory. It's in the same class as ibuprofen and Aleve and things like that. So I think that was an appropriate thing to try. it is anti-inflammatory. It is more systemic and not as directed as an injection would be.
And it sounds like she's had the physical therapy. That hasn't worked, so it sounds like injection would be the next.
I think it's entirely appropriate to try that at this point. Because one, I'm sorry to hear about your troubles, but two, I applaud your efforts in physical therapy. I think that's a perfectly good place to start for all of the pains that you were describing. And injections can be helpful with each of them as well.
Thank you very much, Charlie. Let's go to line 5. Ardeen calling us from Luling tonight, Doctor. Ardeen, go right ahead with your question.
Yes, I'm calling in behalf of my mom. She lives in a nursing home. Now, she fell and has broken the shoulder, and all the way down to the elbow there's a plate. Now, she came out of there and didn't want to exercise, so it's sort of frozen. Do any of these injections, would that be helpful to her? She has arthritis.
They certainly can be. I think oftentimes we give an injection and it calms down irritation or inflammation enough to assist people in doing more activities, including the strengthening, including the exercise. I know it's hard motivating certain folks in terms of doing the exercises, but sometimes the injection can be a good motivator just because it gets rid of some of the irritation, it gets rid of some of the pain.
Ardeen, thank you very much, and best of luck to your mother. Let's go to line 6. Al calling us from New Orleans. Al, you're on Hello Health with Dr. Andrew Gottschalk.
Yes, good afternoon, doctor. I have a herniated disc at the base of my neck, and my left arm is constantly in pain. I've had some therapy, but I'm considering the surgery, and I'm interested in this injection therapy. What's your thoughts?
I think injection therapy is absolutely appropriate to try before surgery. Spinal surgery can be very effective, but it can also be very risky. And injection therapy is rather safe. I would say I would personally try an injection before most surgeries. I mean, if I was in a car accident and I needed surgery right now, then give me surgery right now. If I could wait for a bone or joint related problem, it's worth trying an injection.
And in almost every case, it's going to be much less expensive than a surgery.
Absolutely.
All right. Let's go to line 1. Glenn is calling us from Harvey. Glenn, you're on Hello Health. Good to have you with us.
Yes, I have 2 pinched nerves in my lower back, and I was wondering what injections. Let me say this first. In 2011, I had an injection, and I also had one in 2012, and they seemed to relieve the most of the pain.
What kind of injections?
I'm at the point now where I really can't walk that far. It's like having a sprained ankle or sprained wrist in my back, and I have to just stop and sit down for a little while, whatever I'm doing.
What kind of injections were they?
Oh man.
Steroid or gel?
Oh, steroid. That's what I wanted to say.
Okay.
That would make sense. So you had a couple of them and they were effective?
Yes.
And you're thinking about having more?
No, I'm wondering, what would your suggestion be for that? I don't know if I should go back and get
a different type of injection.
Yeah, right.
Right. I think it depends how much pain you're having. I think if the steroid injections work well, then you should stick with those. And if you need one once in a while, they're relatively safe, they're effective, and you should continue along that path. If they do not work, or have stopped working, or work less well than they did in the beginning, then you should absolutely talk to someone about one of the more advanced therapies.
Glenn, thank you so much. Lots of callers tonight. Let's go to line 2. Joel is with us from Marrero. Joel, good to have you with us.
Hi. It's nice to hear this. I have had injuries to my neck and my back. I was told that I'd be quadriplegic within 6 months if I didn't have a neck surgery. I signed the papers that day, and Godiva bone was put into my neck, and I'm fortunate that it is growing. And besides the pins and screws that are obvious, I'm doing well with my neck. Prior to that, I had 3 years or 3 different times of cortisone injections, which the first one worked for 4 weeks or maybe 5 weeks, and the second one worked a little longer, but the third one didn't work at all. And they were done in 2 areas, my neck and my lower back, because I have some type of herniation that is pressing on the nerves in my lower back. And I was curious about the gel injections and if there's a possibility of you even considering a study on these stem cell injections. I'm a medical professional, so it helps me understand the inflammation, but like one of the previous gentlemen said, that he can walk for a short period of time and then he's got to rest. I'm almost at the point where I can walk for a period of time and I need to lay down.
Let's see what the doctor has to say.
Well, first, I'm sorry to hear about your troubles. That sounds very difficult. What kind of a medical professional are you?
I'm a pharmacist.
You're a pharmacist?
Yes.
That's wonderful. I do think that there's a role for trying other types of injections in the spine. I don't think, again, they are so new, there isn't a lot of data out there. There haven't been a lot of scientific studies done showing that. And I think what that leads to is a problem in getting insurance companies to pay for it. So would it be worth trying viscosupplement in the spine? Sure, why not? I mean, the risks of it are negligible. It'd be difficult getting an insurance company to pay for it.
And about rough number, and I know you don't do the billing, but give people a rough number of what these are going to cost them.
It's funny because the billing offices purposely keep the doctors stupid, but I have a general idea when it comes to it. It's $300 or $400 out of pocket for the viscosupplement, the gel, when it's not in an approved place. The approved place is really the knee. It's been studied a lot in knee osteoarthritis. The platelet injections in general are about $500 a pop. The stem cell injections are about $2,000 a pop.
Okay. Thank you, Joelle, for your question. This is our last phone caller of the night, line 3. Helen is next. Helen, thanks for being with us. Your question for Dr. Gottschalk.
My goodness, I'm glad I waited. How are you?
I'm well. Thank you for calling in.
Thank you. Yes, briefly. I've tried to write this down. I'm just trying to project what might happen in the future. I am now 63. And in 2000, at 48 years old, I was struck by a car and flipped over, landed on my butt, and L1 to L5 was fractured. I've had problems with this over the years, and I have to move sort of in a straight fashion, walk like a Marine, I think I say. But I don't know what to expect because there was no treatment. It happened in Florida. There were several days in between that, plus a visit to an orthopedic person. So I feel okay if I stay straight. Straight means stand up or lay down. Sitting is a real problem, and I have a desk job. So I guess, predict the future if you can.
The future of your spine?
Yes.
I think trauma is directly related to degenerative changes, osteoarthritis. So if I am you, regardless, and this is going to sound a bit like what I said earlier in the show, I'm going to keep the weight off for my entire life. I'm going to keep the muscles that support my spine strong, my core musculature, my lumbar musculature. I'm going to keep as strong as I humanly can, regardless of injections, regardless of surgery. And I'm going to do those two things as though my comfort, my happiness depended on it. To calm things down, I think an injection now and again would be entirely appropriate. I would save surgery in that case as a last-ditch effort, as a last resort. But I would keep the weight off, I would stay fit, I would keep the back strong, and I would consider an injection if you needed help getting through a period of irritation.
And from what it's worth, and I've seen them advertised now, they're standing desks. So if you have a desk job and you need to stand up, obviously you can't sleep or lay down and do your job, but you could stand up. So one other thing to throw out. Well, I want to thank Dr. Andrew Gottschalk for the education and information he has provided tonight and for his continued work in the Oxnard Health System. Great to have you with us, and welcome to our city. Thank you for being a part of it. Yeah. Well, to make an appointment with any Oxnard physician, including tonight's guest, or to register for any of Oxnard's Hello Health seminars, you can call Oxnard at a special number set up just for viewers of this program, 842-5669. That's 504-842-5669. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Oxnard's website at oxnard.org. Our thanks again to tonight's guests. Thanks to Humana and Oxnard for making our program possible. And our final thanks to you for your support of our program Hello Health and our station, WLAE.
Hello Health on LAE is presented by the Oxnard Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxnard Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxnard, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.